Session on abdominal issues in the intensive care unit. So my name is Lioudmila Karnatovskaia. I'm from Garches, southwest of Paris in France. Hashim.
I also like to welcome you. My name is Achim Juras. I'm from Cologne, Germany. Pleasure to be here.
So hope you're all ready to start, and we will start with an important topic about the microbiome in our patients and which role the microbiome is playing in host response and in abdominal issues in particular. Welcoming Lioudmila Karnatovskaia. The microphone podium is yours.
Thank you very much. All right, well, thank you everybody so much for being here, for Jean-Louis for inviting me. We'll talk about the role of microbiome in the ICU and beyond that, as there is increasing recognition of the role of microbiome that plays in all aspects of our lives. When you think of what makes us human, some people think that it is our cells that make us human, but only half of our cells are of human origin. Some may think it's our genes that make us human, but only 1% of our genes is actually of human origin. The rest is bacterial, and therefore we're basically a walking ecosystem. For the purpose of this talk, I'll mention microbiome as primarily bacterial, but it's composed of also viruses, fungi, and their genomes. It's very dynamic throughout our lifespan and increases in diversity until about the age of 12. It becomes relatively stable as we are adults, and then it declines with aging. Over 35 species of bacteria have been isolated. Primarily, it's anaerobic bacteria of genera Firmicides and Bacteroides that play a major role in metabolism, in the immune system. They protect us from pathogens, and they help to synthesize vitamins, amino acids, and to digest fibers, producing short-chain fatty acids, which are likely the key mediator between microbiome diversity and health, as they promote apoptosis of cancer cells, they mitigate inflammation, they have lots of roles in neurotransmitter pathways, they help to regulate satiety and appetite. And diversity of microbiome has been linked with health and longevity. Studies on centenarians and supercentenarians revealed that people who live healthy to that age have very, very high microbial diversity. And unfortunately, in a lot of us who live in the industrialized world are exposed to processed foods, sanitation daily in the hospital, antibiotics, and other factors that reduce bacterial diversity in our biomes. And loss of diversity has been associated with lots of different illnesses. There is pretty much got everything pathway nowadays. What happens when we land in the ICU is most of our interventions are beginning to be linked with the loss of bacterial diversity. Most of our commensal flora is lost within hours of onset of critical illness. And pro-inflammatory cytokines trigger changes in the tight junction proteins in the gut, which allow the gut to become very permeable, leading to bacterial translocation, dysregulated immune system activation, inflammation, apoptosis, and the shift in the microbiome towards what's been termed as a pathobiome. What interventions have been so far linked of what we give to also loss of bacterial diversity? There has not been any data that I could find for usual ICU analgesics like fentanyl, but a lot of data has emerged from morphine, mostly from animal studies, such as it's been found to induce epithelial barrier dysfunction and to facilitate bacterial translocation into the mesenteric lymph node. And even after 1 day of morphine treatment, the mice that was exposed to morphine had very distinct difference in the microbiome between the morphine group and the non-morphine group. It also, morphine increased preferential expansion of gram-positive bacteria and increased in communities that were associated with pathogenic function. PPI prophylaxis, another very, very common intervention, has been linked to a dramatic drop in Shannon or alpha diversity, which is basically how much diverse your biome is. It facilitates growth in pathogenic genera like Enterococcus, Staph, E. coli, and overall increases the risk of intestinal infection, explaining how dramatic rise in incidence of C. diff infection. It also apparently promotes NSAID enteropathy by creating an imbalance and decrease in actinobacteria and bifidobacteria, which then augments expression of bacteria with beta-glucosaminidase activity, and it results in entering of NSAIDs into enterohepatic circulation with cytotoxic bile salts, then facilitating the enteropathy. Antibiotics are well known to decrease microbial diversity and select for bacterial resistant strains to make hosts more susceptible to have other infections like with C. diff. They can also impact transcription of functional genes that are known to encode metabolism of carbohydrates and protein synthesis, which leads to downregulation of short-chain fatty acid synthesis, which may in turn contribute to the sarcopenia we see in the ICU patients, but that mechanism has not been really looked at in any detail. Recently, a study has been published in the European Respiratory Journal of a retrospective review of data of over 3,000 admissions for VAP pneumonia. And they looked at whether there was any association of antibiotics with anaerobic coverage, which you don't need for VAP, with outcomes. And the controlling for multiple factors, they found that exposure to antibiotics with anaerobic coverage, even one dose of Zosyn decreased survival in the VAP patients. And one dose is enough to wipe out most of your commensal gut bacteria. So whenever you think of giving somebody broad coverage, it made me really think twice whether or not I need to give that Zosyn or Flagyl or whatever. So other interventions that we do, for example, bowel regimen. Who isn't on bowel regimen in the ICU? It also decreases gut diversity, and it decreases the amount of lactobacilli we have that is very beneficial. In a mice experiment, mice were given PEG in their drinking water for 6 days. And here you can see, oops, sorry, the other way. You can see the nice thick mucus lining in green on day 0. And on day 6, you see there's almost no mucus lining. So it's also not a benign intervention. Other interventions that have been associated with loss of bacterial diversity include antipsychotics. More interestingly is that the bioavailability of antipsychotics actually depends on the biome, which may explain why people react to them differently. Prednisone also has been linked to increased bacterial translocations through the intestinal wall and impaired killing of translocated E. coli. Tube feeds. They are not really been designed when the microbiome data has become available. Sometimes they have things like corn syrup. High fructose corn syrup has been linked to loss of bacteria that produces butyrate, one of the short-chain fatty acids, and it also decreases microbiome diversity, specifically bacteria that decreases adipose tissue. Mice exposed to high fructose corn syrup had increases in fat, triglyceride, glucose intolerance just after 6 weeks. And if you have given them to patients who have cancers, a lot of cancers have an enzyme, ketohexokinase, that convert fructose to fructose phosphate, and it leads to enhanced cancer cell growth. Another ingredient that I've seen in tube feeds is the synthetic emulsifier, like a carboxymethylcellulose. It's been linked to decrease in microbiome diversity, decrease in short-chain fatty acids, amino acid synthesis, promotion of intestinal inflammation, increasing in E. coli virulence, and increasing levels of bioactive lipopolysaccharide. When you think of nutrition-related diarrhea, people on tube feeds quite often develop diarrhea. And when they looked at stool samples of people with and without diarrhea, the stool samples of people with diarrhea had a profound loss of anaerobic bacteria, although what is primary and what is secondary is hard to tell. But when you compare enteral and parenteral nutrition, the patients with enteral nutrition have increase in aerobic bacteria and decrease in anaerobic bacteria, and TPN patients have decrease in both. So it's been postulated that perhaps the bacterial imbalance is one of the drivers for the diarrhea seen in enteral nutrition patients. Parenteral nutrition has been linked to increasing levels of proteobacteria that promotes inflammation and can cause epithelial barrier breakdown. Enteral nutrition also often don't have a microbiome in mind, as a lot of the preparations are absorbed very proximately in the GI tract and don't have a lot of soluble fibers. Why is it important? Is that in one study, looking at the fecal samples from ICU patients, they were the same as fecal samples of the corpses. That's not normal. And another study looked at the rate of bacteroides and firmicides, and they found that people who died in their very small 12-sample group actually had extreme imbalances in those ratios. So they postulated that perhaps gut microbiota may be associated with prognosis in critically ill patients. It's emerging as basically another organ that we're just beginning to learn about. Your patient does survive. What do you recommend to them? How can they restore their bacterial diversity? You just give them a probiotic? Well, actually, a study from Stanford, a group from Stanford, looked at whether probiotic supplements can restore diversity and to help reduce markers of inflammation, and whether or not they help with any kind of metabolic function. So they did a 10-week intervention, and they found that there was no change in the participants' biomarkers, there was no change in microbial diversity, and there was no change in inflammatory cytokine levels for their small sample group. When they looked at every single participant, as it was a small study, they noticed that a few people actually had been classified as responders, the parts that you see in dark blue. When they looked at what makes responders responders, they realized that responders were eating more plants. So can you just advocate a high-fiber diet to the patient who comes to your post-ICU clinic? Well, actually, those people have lack of bacteria that are necessary to digest complex carbs. So it may not be the best initial diet. The same group from Stanford looked at what is the diet, if any, that can help to restore biome diversity. And they compared high-fiber diet with high-fermented food diet. They did a 4-week ramp-up and 8-week intervention, where participants were eating up to 6 servings of either fermented foods or high-fiber foods per day. In the high-fiber arm, they noticed that mostly participants had increased amount of enzymes that are needed to digest the carbs, but there was no really much change in microbiome diversity, which they were quite surprised about, because complex carbs is really what your gut biome is supposed to need from all the literature. But there was a small change basically in people who had low inflammatory markers at baseline. And so the increasing soluble fiber was not effective in improving inflammation markers. High fermented food group had very different results. And by fermented food, I meant they mean something like probiotic fermented food, active living food. So kombucha, yogurt, kefir, kvass, sauerkraut that has not been pasteurized, something that you find in the refrigerated section of a supermarket. And the serving was 6 ounces of liquid, or 2 ounces of like a brine drink, or a quarter cup of veggies. So people were eating up to 6 servings of these per day. They could choose any fermented foods they wished, which is a beautiful thing. And they noticed that they had a great decline from before and after in just a small sample group of all the inflammatory markers. And they had tremendous signal for increase in microbiome diversity. So when they looked at, okay, so where did all this diversity come from, they went and they purchased every single food that the participant documented that they ate. They put them on agar plates, and then they realized that only 5% of the change in bacterial diversity could be explained from the bacteria that they found on agar plates. The rest happened synergistically. So just to summarize, microbiome is a new organ that is likely will its own place in the ICU, and it affects many pathways in health, disease, aging, longevity, and the decrease in microbiome diversity has been linked with disease. Diversity falls rapidly after ICU admission, and a lot of our interventions that we do as a standard of practice, when they became standard of practice, microbiome was not an entity that anybody thought about. So perhaps imbalance in the microbiome has a prognostic implication, and maybe a diet high in fermented foods, or at least containing fermented foods, can help your patients to recover after critical illness. Thank you.
Thank you. Thank you very much for this interesting talk that's open for comment or questions from the audience. So, yeah, please.
There was a study investigating probiotics for pancreatitis, which showed actually worse results in those patients treated with probiotics. What do you think about that, about this result with regard to your data?
So probiotics and fermented foods are different things, because probiotics, once it's a supplement, and I'm not advocating giving supplements to people who are acutely ill, the results, if you investigate food, may be different than when you investigate a supplement, because as you know, if you eat an orange and you take a vitamin C, the availability and the result will be very different. So they're not one and the same. So right now, there is no data on using fermented foods in critical care setting. We're actually doing a study on giving kefir to the critically ill, but we are excluding pancreatitis patients and people without intact gut, because they're a completely different group of people. But if you add foods that are fermented in that setting, you may have different results than what you get with supplements, but it's more difficult to do that research. But I think it will be done, and then you will have an answer.
Any other question? So, may I ask you one question? Do you think that microbiota diversity should be part of the routine assessment of our critical patients, all comers, those at high risk of sepsis, for example? And because we're taking samples from blood, from the urine, and we know there is increasing evidence of the role of the microbiome in regulation of the immune response, for example. So what would be your advice?
Well, in the world of utopia, my advice would be more data is better, because right now we have minimal data, if any, on the microbiome perturbation and the role in prognosis and in outcomes. So collecting more data would be, by me, always welcome, but it's not cheap to run the microbiome analysis. So.
Okay, thank you. That's very, yes, one more question?
Just do you have a simple answer to a complex question? Do you have an optimal enteral feeding formula which you would per now recommend using?
I don't. I just would like to be more aware of the ingredients and try to avoid something that, at least with synthetic ingredients and fructose, corn syrup, and things that have been tied to gut imbalance. There are multiple tube feeds that don't have that stuff, so, but I don't know specifically which one I would recommend.
Thank you very much again.
Okay, we now move on to the very important question: how do we protect the gut in critical illness? And this presentation is given by Dr. Craig Coopersmith.
Thank you. So I'd like to thank the organizers for inviting me, and I'd like to thank the previous speaker for setting up my entire talk perfectly. We did not talk in advance, but my entire talk is going to be about targeting the microbiome. My disclosures are the exact same as they were this morning when I talked about permeability in the gut in critical illness. So the nice thing is I could skip this slide because she said it. I could really skip this slide because she said it too, but this paper which she referenced, this figure never actually made it into the paper. This was originally part of it, and the reviewers didn't like it and made them change it to something which was worse. So this figure from Paul Wischmeyer is the best thing I've ever seen of looking at what our patients look like versus what we look like. So if you take all 40 trillion microbes and you bring it down to a single dot, we are red and our patients are in blue. And I've never seen a better description of how different we look from our patients. She said this. She said this. She said this. She really didn't, however, focus on the ICU, which I will do for my entire talk. So, of course, there's an association. Association is not the same as mechanistically responsible. There's an association between the pathobiome and 28-day mortality in critically ill patients. There's an association between the gut microbial outcome and 60-day mortality after COVID. This paper came out 3 days ago, and I had to change my talk. Anybody who heard me this morning, I added it to my talk this morning as well. The title rolls off your tongue. Dysbiosis of a microbiota immune metasystem in critical illnesses associated with nosocomial infections. It's a really straightforward title. And when you bring it down to the bottom, what it actually is talking about is dysbiosis of an interconnected metasystem, which is the term I like, between the gut microbiota and the systemic immune response, drive impaired host defense and susceptibility to nosocomial infections. Because English is my native language and it's still very difficult to understand that, I'm going to bring this down into one beautiful figure from this paper. This is looking at the microbiome that's enriched in Enterobacter versus not in ICU patients on mechanical ventilation. The graph on the left is the chance of making it out of the ICU without a nosocomial infection. Patients who had enrichment for Enterobacter had a markedly lower chance of making it out of the ICU without a nosocomial infection. But if you look on the right, the infections they got were not Enterobacter. They had no increased chances of getting Enterobacter infection, but they had a 7-fold increase of getting a nosocomial infection. So the microbiome is impacting our immune system, is impacting the secondary ability to get nosocomial infections. So again, beautiful thing, because I was thinking, wow, 15 minutes isn't that long. All I need to do is have her speak before me every single time, and I can just skip slides. And so everything else is going to be clinical, unlike my talk this morning, which is a lot more basic science, is can we alter the microbiome at the bedside? So what are conceptually things we can do to alter the microbiome? And I'm not going to talk about fermented substances here. So we can, quote unquote, increase the good bacteria. I think Jalali asked about that, with probiotics or prebiotics or symbiotics. We can transplant bacteria by doing stool transplants or fecal microbial transplant, or we can do the exact opposite. I'm sure there's somebody here from the Netherlands who does selective decontamination of the digestive system, the exact opposite. Instead of increasing the good bacteria, decreasing the bad bacteria. And so each of these has been shown to work to some degree, and I'll, spoiler alert, tell you, somebody asked me the question, do I do any of them? No. Is any of them standard of care outside of very specific circumstances? No. Although I will acknowledge that some countries you might be in, you might be doing STD. So we're going to start with the so-called increase the good bacteria. Before I got off the plane from the United States a couple of days ago, we looked at, I looked at PubMed, I update every time I do this talk, probiotics, which are exogenous live bacteria, prebiotics, which are non-digestible nutrients that stimulate commensal bacterial growth, and symbiotics, which is the change. And you have the number of references there in PubMed and the number of references for those and sepsis, not critical illness, but just sepsis alone. So, do probiotics work? Here's 3 meta-analyses, and I want to point to the bottom of this. Every one of these was published in 2021 or 2022. There's somewhere between 15 and 25 studies of somewhere between 2,000 and 5,000 patients. And I find it amazing, as you think about meta-analysis at the bottom 2, they're both 15 RCTs, but one of them has 2,000 patients and one of them has 4,600 patients, which actually tells you what all you need to know about what do we actually include in a meta-analysis. But if you put all of these together, what you find is different results depending upon which studies you include. Ventilator-associated pneumonia may be decreased. Mortality is not changed. Conclusions are limited by low-quality evidence, heterogeneity of study design, and outcome measures. And remember, I showed you every one of those was published in 2021 and 2022, and they're already entirely out of date. Because this came out, effective probiotics on ventilator-associated pneumonia in critically ill patients. This is using a specific probiotic, Lactobacillus rhamnosus, in 44 different ICUs. Large study, 2,600 patients. And ultimately, if you get to the end, probiotics didn't change anything. If you like figures for saying that, here's figures for saying that probiotics in subgroups don't change anything. at least this specific probiotic, and this is by far the largest study done to date. And they were associated with increased adverse effects. In a small number of patients, but not zero, they were able to find the probiotic outside the gut in places where it's not supposed to be. There was translocation, and again, I'm happy to talk about permeability. That was my talk this morning, but clearly the probiotics got out of the gut lumen because there is hyperpermeability through 3 different pathways in the gut, and they ended up where they're not supposed to be. And now you put it into the most recent meta-analysis, even though all of them published very recently, probiotics in critical illness, a systemic review of randomized trials. So I'm going to have a top conclusion and a bottom conclusion. 65 randomized trials, 8,440 patients. Probiotics may reduce ventilator-associated pneumonia. That's good. Healthcare-associated pneumonia. That's good. ICU length of stay. That's good. Duration of mechanical ventilation. That's good. That's all great, right? So maybe we should be using probiotics. Until you get to the bottom, probiotics have no effect in mortality, and post-hoc sensitivity analysis without high-risk of bias studies negated all the benefits. And so if you take the high-risk of bias studies, probiotics look really good. When you only include the low-risk of bias studies, not only is there no effect of mortality, there's no benefit on all the other things that we typically talk about as being the benefits of probiotics. By the way, this doesn't mean that probiotics aren't useful in the future, in our utopian future, but in our utopian future, we're going to know the patient's microbiome, the precision medicine for what to potentially give them at the right time, at the right drug, et cetera. Just like we don't just say, doesn't matter what antibiotic. You said Zosyn is a bad thing. Does Zosyn help everybody? No, Zosyn doesn't help everybody. Zosyn helps a particular subgroup. And so is one type of probiotic good for everybody? No, there's no good data that one type of probiotic is good for everybody. Unless you're a neonate. If you're a neonate, and I do not take care of neonates, here are 63 trials of 15,000 infants with a combination of 2 different things. And look at this, all-cause mortality odds ratio of 0.56. So the data, and if there's any neonatologists in here, you can explain it to me. I didn't go that in depth in it. But the data in neonates is incredibly robust, but not in adult patients. So moving on to stool transplant. Who here has ever done a stool transplant or seen it done? 4 or 5 people. Who here thinks it sounds disgusting? Okay, I'm going to change your mind, although somewhat, it still sounds disgusting. But this is what immediately changed people's mind. This is not in the ICU. This is in recurrent C. difficile colitis in patients on the floor. Duodenal infusion of donor feces for recurrent C. diff. Again, sounds gross, right? Oral vancomycin compared to bowel lavage, compared to fecal microbial transplant. Primary endpoint is cure after 10 weeks. Stopped early for efficacy. The efficacy of 30% versus 23% versus 94% cure with no side effects and restoration of microbial diversity. What sounds disgusting when you go from a 23% cure to a 94% cure sounds like a miracle drug. And all of a sudden, that sounds pretty amazing. Now you say, this is now 10 years old. What's more recent? Actually, the most recent meta-analysis I can find is actually still pretty old. 37 studies, including 7 randomized trials. Fecal microbial transplant more effective. Again, this is in recurrent C. diff. This is not in the ICU. In recurrent C. diff with a resolution of 92% and an odds ratio that's insane, right? A relative risk of 0.23, something we will never, ever see in the ICU unless Jalali's doing this study, then maybe. And this happened a couple of months ago in my country. The FDA approved the first fecal microbiota product. And this is a drug called Rabioda, and this is giving it per rectum. So all of a sudden, it's not just kind of like take a donor stool and just kind of like give it and do it however you want in a non-reproducible, non-standardized way. It's actually an approved drug right now to give donor stool per rectum for recurrent C. diff. Why don't we do this all the time in the ICU? So first of all, we'd be giving bacteria to somebody with an altered microbiome, and what that would do, we're kind of unsure of. As just pointed out, 70% of the people in the ICU get antibiotics. And if you initiate or continue antibiotics, by definition, it's going to change the stool transplant you're giving. So there really has to be a commitment to stopping and continuing to stop antibiotics, which is incredibly hard in the ICU. And here's a nice thing for the New England Journal about drug-resistant E. coli bacteremia. transmitted by fecal microbial transplant, in which one of the patients actually died. And they were able to actually do the environmental thing to actually see it directly came from the stool transplant. In select cases, should fecal microbial transplant be used in the ICU? This is the world's literature on it. Everybody ready? There you go. 5 case reports, though most of them were in Jean-Louis' journal. So it is I'm sure there have been more people who've done this, but the world's case report is only 5 patients. Having said that, here's a new technology that may make the technology easier to use and more standardized. So this is, I don't even know how to pronounce this. It's SIR-109 or SER-109. It's an oral microbiome therapy for recurrent C. diff, again, not in the ICU. I think the best way of putting it wasn't in the paper, it was from this. And what it is a stool from donors is treated with ethanol, which kills viruses, fungi, and vegetative bacteria, leaving behind bacteria that can form hardy, thick-walled structures called spores. And that's what you're actually giving to patients. So a remarkable effect in patients in recurrent C. diff. Oral. And 2 papers that have come out in the last couple of months. Now we have extended 24-week follow-up for patients who are given this. And something that came out last week in JAMA Network Open is looking at the quality of life on these patients. And they had improved quality of life very, very rapidly that was durable. So at least, again, not in the ICU right now, but stool transplant given in pill form or just the spores of stool, durable 24-week long-term outcome, microbiome stays, C. diff stays away, quality of life much better. In the last couple of minutes I have left, we're going to talk about STD. It's the exact opposite. Although I would make the argument that the S is really wrong because it's not really selective in any meaningful. It's actually to take away pathogenic bacteria, but I wouldn't make an argument it's targeting 1 or 2 things in the pathobiome. So here we go. After I just said that nothing ever works in the ICU, here's a meta-analysis of 41 trials with 11,000 patients showing STD decreases mortality, not pneumonia, but mortality with an odds ratio of 0.84 and decreases respiratory infections with an odds ratio of 0.43. Show of hands, who uses STD here right now? Show of hands who uses it if you're not from the Netherlands. 2, okay. So it doesn't mean that the people using it are wrong, and it doesn't mean that the people not using it are right. It's context dependent, right? So even topical antibiotic prophylaxis may decrease mortality. So it's remarkable. So here's something like nothing we do decreases mortality, and this decreases mortality. Why didn't everybody raise their hands? Why was it a subset of people who raised their hands? They were all done in ICUs with low baseline antimicrobial resistance, mostly in a single country. And if I lived there, I would do it too, because the odds, the data are remarkable. But since then, outside of that, decontamination strategies and bloodstream infections with antibiotic-resistant microorganisms in ventilated patients, a randomized controlled trial. Okay, how many are we talking about? 8,600 patients. No difference. Maybe you don't believe that. Effective selective decontamination of digestive tract and hospital mortality and critical illness, receiving mechanical ventilation. A different trial. 5,982 patients. No difference. So let's go to the new meta-analysis. Association between STD and hospital mortality in the ICU. And to some degree, this is a Rorschach test, depending on how you view this. So if you look at this in the bottom, it's still positive. It's not as positive as the Cochrane database, but it's still a positive trial. So we should be all doing this. That's a positive study. Except for if you look for all the recent studies. All the recent studies are all the large studies, and all the recent studies or all the large studies are being done not in places with low antimicrobial resistance, and they're not showing any effect at all. So the people who use it, you've got data to support you, and I applaud you. And the people who don't, you've got more recent data, probably looking at what your baseline ICU looks like, and you're not using it, and I applaud you as well. So in conclusion, the microbiome mechanistically plays a role in mortality from sepsis. In preclinical studies, I didn't show that, of course, and is associated with mortality in clinical studies. The microbiome can be targeted in the ICU in multiple different ways. Each of these shows promise, but they're limited by logistic concerns and heterogeneous and awfully low quality data. And by the way, when I talk about how to evaluate the immune system, Jalali, at 4:30 this afternoon, I will be specifically talking not only about how you evaluate the immune system, but how you evaluate the microbiome as well. And with that, I'll say thank you very much.
Thank you very much for a great presentation. Do we have questions? I would have one question. So we earlier heard that there is thousands of different bacteria in our bowels.
Yep.
So why is it that there is only a handful actually causing infections in relation to the number there are? So it's always the same bacteria if you have organ perforation or translocation or so that actually cause serious infections.
Yeah, so I want to disavow the concept that mostly our bacteria are translocating. So there was actually a great study that I can't believe got through an ethical thing, but did, in a trauma patient population where they actually took catheters and they put them in portal veins of trauma patients 1, 6, 14, 24, or 48 hours after trauma. And this is back in 1991. And they found that they were able to identify bacterial translocating in 2% of patients. And of the 8 patients they found it, 7 of them are coag-negative staph, which doesn't live inside the gut. So the concept that bacterial are translocating is generally actually not the case. I understand that if we have neutropenic patients that they might actually have such a profound change in the gut barrier. Again, when I gave my talk this morning, the gut barrier is actually more complicated than we think it is. There's actually 3 different pathways, and 2 of them, the pore and leak pathway, are too small to let bacteria through. The only time that bacteria can get through, and that is a tight junction independent. If you have issues with apoptosis, like our first speaker spoke about, epithelial damage can actually lead to intact bacteria going across. So in a very tiny, tiny group, when you have gut barrier dysfunction, not through tight junctions, intact bacteria can come across. So the reason the microbiome is affecting us is not translocation of those 40 bacteria, or else everybody would have E. coli bacteremia. It's actually the incredibly complicated microbiome that our previous speaker spoke about, having bacterial products going through smaller things that are not actually intact bacteria, that are changing the immune system, that are changing the host response.
Okay.
In the 6th round.
There is a question over there.
Yes, hello. Thank you for your presentation. My name is Benjamin from Chile. I don't know if there's an answer for this question, but in your personal opinion, what is the time frame for ACT in this case? Because, for example, in infection, we know that the sooner we give the antibiotic, the better. And here, is there a time frame that you say, okay, when we start refeeding the patient, or when the patient is off the hook infectiously, when do you start attacking the microbiome problem?
Right. So the when do you start feeding is a separate question from when you start the microbiome. That's for nutrition experts. The microbiome is changed literally within an hour of the ICU, but I would make an argument that we do not have an effective way of understanding what interventions are the case. Hypothetically, if we got to the same concept of precision medicine for the microbiome, it would be the same as with the antibiotics. If you knew that somebody was septic, knew what the bug was, you would want to treat them as rapidly as possible. So hypothetically, if I knew what was changing in this incredibly, incredibly diverse microbiome, I would target it as soon as possible. But I don't know that we know even what to treat with before I even talk about the timing.
Okay. Further questions? More questions? If not, we move on. Thank you very much.
So we move on to our next speaker, Angelique de Man, was going to talk about complications of esophagectomy.
Good afternoon, everybody. In the next 15 minutes, I will discuss with you a lot of complications after esophagectomy, and I would like to thank our surgeons, Mark van Bergen-Henegouwen and Wietse Lameres, for providing data and several slides. I have no conflicts of interest, and I would like to discuss with you esophageal cancer because it's the 6th in worldwide cancer-related deaths. It has a poor prognosis due to a late diagnosis, and it has a substantial mortality rate. However, this mortality rate has decreased from 71% to 4.5% in the last 33 years. And there is, amongst others, a substantial complication rate because the preoperative condition of these patients is often very bad, and also because they have often preoperatively chemotherapy or radiation. And when I tell our nurses that we are admitting a patient with a status after esophagectomy, mostly they react like this, because they know that our patient is up for a long-term care in our unit. They mostly stay at least several weeks, but mostly several months. And it's sometimes difficult to keep all the nurses and also my colleagues enthusiastic for this patient, because they think he has no chance to survive. But many times we see these patients after several months at the outpatients clinic or in the restaurant of our hospital, and they are doing fine. However, they are up for a very long stay. And first of all, it is important to understand what kind of operations these patients have. They can have an anastomosis just at cervical level, at a thoracic level, or sometimes also they may have 3 anastomoses, because there are several different surgical approaches, and the most frequently used are the transhiatal esophagectomy with a laparotomy and a cervical incision. You have the Ivor-Lewis with a laparotomy and a thoracotomy. And you have also the McKeon with 3 incisions at cervical, thoracal, and abdominal level. So it's good to keep in mind these different approaches, because they all have their own advantages. For example, the 3 incision from McKeown, there you have maximal margins of the tumor. You can operate all tumors independent of their location, and but however the disadvantages are that they have an increased risk for pulmonary complications. The transhiatal approach, then you have no thoracic incision and no thoracic anastomosis. However, you have poor access to the nodes, and you need a blunt thoracic dissection. And finally, the Ivor-Lewis, you also have a good access to nodes. You have access to the thoracic duct. I will come back to that later. But the disadvantage is that you have a thoracic anastomosis. So these are the 3 main surgical approaches. And you have a lot of complications. You can have arrhythmias like atrial fibrillation, but and you also have pulmonary complications. However, the most frequent local complications are an anastomotic leak, conduit necrosis, conduit airway fistula, and chylothorax. And I will discuss, because of time, only the local complications. So it's very important to recognize these complications in these patients, because we know that the longer it takes to recognize these complications, the more severe these complications will be, and the more difficult it will be to treat this patient. And you have all kind of grading for anastomotic leakage, and this is the most frequently used, type 1. You can just treat these patients with no medically and with dietary modification. Type 2, then you need interventional radiology, but no surgery. Type 3, then you actually need surgery for these patients. And there are several risk factors in the patients for an anastomotic leakage. For example, patients with a high ASA score and also patients with a lot of preoperative weight loss, because they have a worse preoperative condition, and also squamous cell carcinoma, especially when they are intrathoracic, have a worse prognosis. And it also depends on what type of procedure has been used. So the McKeown has the highest complication rate in our hospital. And when you look at the data of the Netherlands, we can see that the overall leak rate from 2080 till 2020 was 16.7%. And when you look at the data of our hospital, in our hospital we had the highest volume of patients of the Netherlands, and we had the lowest complication rate. And one of the things which probably has caused this low complication rate is that in our hospital, our surgeons use perioperatively imaging with indocyanine green. So they look at the perfusion of the gastric conduit, they choose their level of anastomosis, and depending on how the gastric conduit looks, they change their management. So they see whether there is enough perfusion at the level of anastomosis, because the arterial supply of this gastric conduit depends only on the arteria gastroepiploica. So this is the only artery which can supply this gastric conduit. And how can you recognize the anastomotic leakage? There are several symptoms, however, they are quite aspecific. Tachycardia, atrial fibrillation, fever, pain, respiratory compromise, delirium, so that can also be explained by pneumonia or other problems. The patients frequently have increased CRP levels, and the most frequently used diagnostics to examine whether these patients have a leakage is endoscopy and a CT scan. And we most frequently do both. An endoscopy is, of course, an invasive diagnostic. However, direct treatment is possible, so that's a good thing. And you can treat this patient with a stent or with an endoluminal sponge. And the CT scan, however, then you know whether there is, for example, pleural empyema, and you can drain these pleural fluids. And you can see also at what level the leakage takes place. And it's very important for these complicated patients that you treat them, that you have a treatment plan with multiple disciplines. So with the gastroenterologists, with the surgeons, with the intensivists, and also with the intervention radiologist. And you really need good intervention radiologists to treat these patients. So what are the treatment options for these patients? Important is that you have early recognition, aggressive management, and a multidisciplinary approach. Sometimes it is enough just to have conservative treatment of these patients, especially when there are minimal clinical manifestations. Surgery is mostly indicated when there is early leakage within 72 hours, because then it's mostly a surgical problem, which cannot be conservatively managed. Severe sepsis or failed conservative treatment are also indications for surgery. Of course, you have to treat these patients for sepsis, and also these patients have nil by mouth, nasogastric drainage, and proton pump inhibitors. And now the more local treatment options, because they are getting really advanced in the last years. First of all, of course, you have to close the defect, and you can do this by endoscopic methods or by surgery. And second, you want to drain the collections and the empyema. You can do this by external drains, so you need your intervention radiologist, or internal endoscopic drainage, and then you can also, at the same time, perform endoscopic washing, nasogastric tube with suction you can insert, and you can leave a sponge in the esophagus and perform vacuum drainage. And in our hospital, the gastroenterologist used several devices to cure this anastomotic leakage. They can either inject with a kind of glue. Mostly that is also only possible with small defects. They can clip, and they can put a clip through or over the scope. Also, this is just for small leakages. And they can place a stent, or they can leave an esophageal sponge at that place. However, for all these interventions, there's at this time poor evidence, only cases and case series, because it's quite new. And for example, the stents. The stents, for when you will put a stent in the esophagus of a patient, he will need general anesthesia, endotracheal intubation, and when he's not on mechanical ventilation, there is quite a high risk of aspiration. However, you can at the same time perform endoscopic cleansing and irrigate the esophagus and the lesion. In our department, they perform it at a hybrid operating room, and they, with the aid of fluoroscopy, they pass a guide wire through the endoscope. They mark the anastomosis on the body surface, and they place a stent on the fluoroscopic control. So they place one stent or two stents, and the stent can be in the patient for 4 or 6 weeks, so quite a long time. So the patient does not need to undergo endoscopy every 3 or 4 days. And that it has a success rate, the placing of stents, of about 70%. So that is quite a high number. And the other possibility is endoluminal vacuum therapy. So you have collapse of the esophagus or the cavity. There is adequate sealing of the defect, and there is adequate drainage. And you can place this sponge either intraluminal, so in the esophagus itself, or in the lesion and the cavity of the lesion. So in case of intraluminal placement, you need to change the sponge every 7 days. And in the intracavitary placement, you need to change the sponge every 3 days. So that's quite difficult for the patient who has to undergo several times an endoscopy. However, the results with these sponges and these stents are quite good. As you can see here, this is an endoluminal sponge, and this is how the esophagus looked afterwards. And these are also other pictures with a huge lesion. And this was the picture with the first, after the first sponge, after the 5th sponge, and after the 8th sponge. So you can see how many changes there have been, but you can also see the end result. And there has been some investigation about the comparing stents with the vacuum therapy. And as you can see here, all the clinical endpoints were in favor of the endoluminal or intracavitary vacuum therapy. So what are the surgical options? Surgical options are needed when drainage of collections was not enough with endoscopy, with endoscopic or radiologic drainage. Surgery is also needed sometimes for very severe emphysema with decortication of the lungs. And it can also be combined with endoscopic treatment. So when there are severe problems the surgeons need to do a re-anastomosis, then they may need to shorten the gastric tube. They reinforce the anastomosis with a muscle flap. However, still there is a re-leakage of 25% which then can be treated either conservatively or also again with the isosponge placement. Other complications which can occur is conduit necrosis, so necrosis of the new esophagus. And that is a very devastating cause of the anastomotic leakage, because then they have to resect the whole conduit. And they have to give the patient an end esophagectomy, and they will leave in place the longest possible length of the residual esophagus. However, the patient will not have continuity of his digestive tract for a very long time, so he will not be able to eat for 3, 4, or 5 months. So that's very devastating for patients. And when everything quiets down after 4 or 5 months, then they will perform a colon or jejunum interposition. Another devastating problem is a conduit airway fistula. So a fistula between the trachea, the carina, the main bronchus, with the esophagus. And also this is a very severe problem, mostly with a very bad clinical condition. And also in this case, this mostly needs to be treated with muscle reinforcement. So for now, another problem is the chylothorax. I do not have time to go into detail for this. However, this is also a frequent diagnosis with milky production because the esophagus is very close to the ductus thoracicus. So, in conclusion, there is a high percentage of complications in these patients, which is decreasing in the last decades. Early detection is crucial. There is an improved surgical approach, and there is an enormous increase in technical options. And we have to be patient with treating these patients, because eventually a large percentage will recover. Thank you for your attention.
Thank you. Thank you. Unfortunately, we are very late, so
Okay.
unless there are burning questions, otherwise we'll move on. Thank you.
Okay, so we move on to acute mesenteric ischemia, and Annika Blaser is presenting on this.
Good afternoon, everybody. If I get my slides here somehow. Ah, yes, already it's coming. So acute mesenteric ischemia. Here my conflicts of interest. Industrial ones are not relevant to this topic, but I hold a study grant for studying acute mesenteric ischemia, and the grant is coming from Estonian Research Council. 100 years ago, it was said that mesenteric ischemia diagnosis is impossible, prognosis is hopeless, and the treatment is useless. Did we do better in between? We cannot compare with what we just heard about esophageal cancer, how much they improved in only a couple of decades. In 100 years, we just did recently a systematic review, and we saw that mortality is still 60%. If we looked at before 2000 studies performed before 2000 or after 2000, there was only a minor improvement, actually. And the reason, of course, there are not so many of these patients. Acute, even though esophageal cancer is also not very often occurring disease, but acute mesenteric ischemia probably even less. So we see 6 cases per 100,000 persons per year, and we see 5 out of 10,000 hospital admissions are due to acute mesenteric ischemia. If we compare this with stroke or myocardial infarction, where major improvements have been made recently during the last decades, then of course it is less. However, if we look at the age groups, then we see that in very old patients, actually, the incidence rate is quite high. So we need to know that in old patients it gets much, much higher. And it's not so uncommon anymore. We did also recently a retrospective population-based study, took all the patients in Estonia diagnosed with acute mesenteric ischemia during 5 years. And it was more than 500 patients in total. And we had some groups where no treatment was actually performed since the beginning. So 1/4 of all these patients was decided to go to end-of-life care since the beginning. And another, more than 20%, were decided to stop treatment after explorative laparotomy or laparoscopy. In these 53 patients who received treatment, we see that in-hospital mortality was actually only 33%. But of course, if we put this half of all the patients who didn't receive any active treatment, then we come to the same as in the literature, 65% of mortality. Very important, we looked, okay, it's clear. Some come very late and don't get any treatment, and some come early and they get treatment and they do better. In all of them, actually, it was 24 hours from symptoms to diagnosis. It was not mainly in the hospital, it was at home. Ambulance was coming several times, gave some drugs against pain and left again, and then with the next time brought the patient to the hospital. We did also a survey on acute mesenteric ischemia and asked individuals here and teams. So team was one multidisciplinary team per hospital. Here individuals could be several from one hospital. And asked, how often do you think that the diagnosis is delayed in your hospital? And you see how many thought that it was often. So 2/3 also from teams think that it is often, and some even think that it is always delayed. And then we also asked, what is the probability of emergency revascularization procedures for infarction? If we already know that there is transmural ischemia, is revascularization performed additional to resection of bowel? And here is rarely and never is more than half of all. And also in teams, it's even more, it's 2/3 say that it is never or rarely performed. In the systematic review, we also looked at different types of acute mesenteric ischemia. It seems that occlusive, if revascularized, has got better survival rate, so lower mortality rate, and also mesenteric venous thrombosis has got lower mortality rate, whereas non-occlusive is the same as average. And here you see the average in all these studies that we pooled. Biomarkers. Of course, we would like to have biomarkers to diagnose acute mesenteric ischemia early, but here we are really nowhere. We are now performing a new such systematic review because it is 6 years since the last one was published, but it doesn't look that we will get from there something. So number of studies is a bit higher now, but not much. Yes. Finnish group did a great study and looked and made actually a quality improvement intervention and started to use management bundle to minimize delay in all phases of diagnosis and treatment of acute mesenteric ischemia. They said, be aware of it, informed everybody, taught everybody in the emergency room, initiate resuscitation immediately, immediately do CT angiography if there is suspicion, ignore glomerular filtration rate, so ignore the kidney function, and write suspicion on the referral letter for radiology. And also immediately involve surgeon, who needs to involve, general surgeon needs to involve a vascular surgeon, and the plan needs to be done multidisciplinarily. And also based on mainly this study, recent guidelines from World Society of Emergency Surgery said strongly recommends immediate performing contrast, so CT angiography in these patients suspected for acute mesenteric ischemia. And the Finnish study, they showed really major improvement here. Almost all patients received contrast-enhanced CT scan. time from emergency department to OR was much shorter. Revascularization was performed much more often, endovascular much more often, and mortality was drastically lower in this study. And also, if it was adjusted, then it remained important. So being managed in the post group remained as a protective factor, even if adjusted for all the other components. Early diagnosis and revascularization indeed can improve outcomes. The site or center that is specifically concentrating in it again and again shows very good results with low mortality at 3 months, 21%. Of course, these are patients with endovascular revascularization, so it is already kind of selection in there. Not all the patients go to endovascular revascularization. And you see that more than half of them did not require any other intervention, but 45% required bowel resection and or surgical revascularization afterwards. However, the results look good. Now we come to non-occlusive mesenteric ischemia, and there was a need to say about non-occlusive mesenteric ischemia that it's a large study taking 61 patients suspected of NOMI, and 33 of them confirmed with NOMI, and 27 had intestinal necrosis. It was not transmural necrosis. It was macroscopically visible and endoscopy or surgery. So surgery, it was usually then obviously transmural, but at endoscopy, it's not always transmural. And you see if the patient had necrosis, then the survival rate was very, very low. They also studied biomarkers, intestinal fatty acid binding protein for intestinal necrosis, so not only for acute mesenteric ischemia, but already more severe where the necrosis was seen, and showed reasonable sensitivity and specificity, let's say. NOMI treatment, here the abstract presented at this meeting here, pooled all the studies that we found in the literature and looked at NOMI and results, grouped based on treatment. So overall, mortality was 44%, surgical management 59%, conservative, twice here, 78%. So not all with conservative dye, obviously, because it's not always transmural. And with vasodilator therapy, it was 27%. Now coming to vasodilator therapy, it seems very good results, right? So it was 5 studies, all of them were retrospective. They used either or intravenous or intraarterial vasodilation. And most of patients actually in the whole group were provided by this study national database from Japan. They looked at 1,800 patients with NOMI over 8 years. And they included 159 from total 161 receiving vasodilators. 2 of them couldn't match with propensity score. They did 1 to 4 propensity score matching, and really, I think it was a good matching. But what we see here is that the in-hospital mortality in vasodilator group was 23, much less than we would otherwise expect, and 34 in control group. They said the number needed to treat is 9, but how was the diagnosis made? It's from database, so it is retrospective analysis. And also abdominal surgery during or after 3 days after admission was low rates. We would propose that the diagnosis and management scheme could look something like this, but this is only a proposal. We try to make it more specific during the next few years. It's important to correct hypovolemia immediately and don't feed these patients where you suspect acute mesenteric ischemia. Immediately perform CT angiography, and if you confirmed occlusion of mesenteric vessel, then you treat with revascularization, with endovascular or surgical, or maybe you use only conservative treatment that is usually recommended for venous. And then there is also not very clear evidence, but to think that for embolus or venous, full anticoagulation is needed, and for arterial thrombosis, antiplatelet drugs are used. If there is no occlusion, then we need to ask, are there signs for non-occlusive mesenteric ischemia? In the angiography, narrow arteries, is it the ICU patient in shock under vasoactive drugs, etc.? And if yes, then correct hypovolemia, aim reduction of vasopressors, monitor intraabdominal pressure, and consider intraarterial or maybe also intravenous vasodilation. If there are signs for transmural ischemia, then obviously the patient needs to go to surgery, and also probably not only bowel resection needs to be performed, but also revascularization. It's not clear about antibiotics, whether it should be given only if there is peritonitis or also in all the other cases. There the translocation issue comes again in question. And of course, you should try to improve intestinal perfusion as much as possible and reduce oxygen demand. And to reduce oxygen demand, it's important to withhold enteral or oral diet until perfusion is assured. And now I come to my summary. Time is issue in case of acute mesenteric ischemia. Outcome can actually be improved with awareness and multidisciplinary management bundle. And also probably if revascularization is performed also in these cases where intestinal resection is needed. Of course, we would like to have intestinal ECG and troponin to diagnose fast, and mainly in NOMI, where we cannot use a CT scan with such a sensitivity as in occlusive acute mesenteric ischemia. Maybe there is something, but we need more studies on this, room for vasodilator therapy for NOMI. And don't give enteral nutrition in case you suspect acute mesenteric ischemia. Thank you very much, and I thank my colleagues.
Thank you very much for an excellent overview. I think we have time for one or two short questions. Well, it was so instructive, there is no need for questions. So thank you very much.
So we move on to the next speaker, Philippe Montravers, who will talk about the use of anti-infective interventions in intra-abdominal infections.
Thank you. Good afternoon. So, may I have the first slide, please? Yes, I pushed it. Okay, so backward. So, anti-infective therapy, my disclosures. So, my first point will be to remember you that surgeon is the best anti-infective therapy that we get. So this is a paper coming from Japan a couple of years ago, gathering 150 cases with peritonitis and septic shock. And the authors analyzed the prognosis of these patients at day 60 following surgery. And as you can see, all the cases who underwent surgery after 6 hours were dead 2 months later. So that means that surgery is absolutely the best and the most fundamental part of therapy. Second point now, in terms of anti-infective therapy, is the fact that since 70s, let's say, we know that we have to treat the pathogens in the abdominal samples and to target more specifically enterobacterials on one side and anaerobes on the other side. Enterococci is a source of debate. We can come back on this point a bit later. Then, and when looking to this paper from Chris Ekman and co-workers, it's a German surgeon, we have here the Western opinion on what are the issues in the treatment of patients with intra-abdominal infections. So we have over there methicillin-resistant Staph aureus, vancomycin-resistant enterococci, ESBL enterobacterales, and then the carbapenemase, and more specifically KPC and metallobeta-lactamase, multidrug-resistant Pseudomonas, and Acinetobacter. As you can see, for community-acquired infection in patients without risk, there is no issue of resistance. Then when you go to the patient with acquired risk factors, usually, so it could be previous antibiotic therapy, previous hospital stay, you'll have some issues, but essentially related to ESBL. Pseudomonas aeruginosa could be a point, but it's quite rare at the end. And then the more you go to a nosocomial or healthcare-associated context, and the more you will face multi-drug-resistant pathogens. So this is something quite well known. And we lived on this basis for the last 50 years. Until this paper from Steenblad and co-workers, published a couple of years ago, gathering in 300 centers worldwide, more than 2,600 adult patients in the ICU admitted for abdominal infections, a quite balanced population, 1/3 of community-acquired infection, 1/3 related to early infection, if ever we can make the comparison with pneumonia, and a large amount, 40% of patients with lately infections. So the first point in terms of microbiology is the fact that there is no major differences between community-acquired, early onset and late onset infections. So here are gram-positive and anaerobes. As you can see, in terms of gram-positive, and not surprisingly, enterococci are the most frequent ones, with a predominance of Physium in this, no, not Physium, Faecalis in this cohort. And then we have anaerobes largely distributed without any peculiarity in this context. Then we move to gram-negative, and if we take again the comparison with pneumonia, there is extremely few Pseudomonas aeruginosa, and the majority of the pathogens cultured are related to enterobacterales, with, of course, the predominance of E. coli and Klebsiella and Enterobacter. And again, there is no major differences between community-acquired and healthcare-associated infections. But when we look at the data from Steenblad and colleagues, and when we look at what happened at a national or international, but regional perspective in community-acquired infection, as you can see, the perspective is quite different from what we used to know. Of course, there is limited number of ESBL-producing strains in Europe, and almost no carbapenem-resistant strains. No issue with gram-positive strains. But when you go to Southern Europe, Eastern Europe, Middle East, and Latin America, there is major problems and large number of multi-drug-resistant strains, as you can see, 50% in some of these cohorts, suggesting that even in community-acquired infections, and probably related to the large distribution of these strains in the community and in the bowel flora of normal people, we will see this kind of organisms. And when you move to the most severe cases, so the late cases, we will have exactly the same picture. So let's say that the Western Europe is quite preserved, and then the more you will go to the east and to the south to some extent, and the more you will have some emergence or positive samples with multi-drug-resistant pathogens. In addition, a second point to take into account is the duration of stay of the patient in the hospital. So this is a cohort we studied in my hospital 10 years ago with 100 ICU patients who underwent repeated surgery for persistent peritonitis. And as you can see, from white initial surgery up to dark blue, late and repeated surgery, at least the third reoperation, we will see a progressive increase in the number of multi-drug resistant strains in gram-positive organisms and massively Enterococci faecium. It could be also for gram-negative organisms, and it could be at this time Enterobacterales, and also non-fermenting gram-negative bacilli, meaning this time that Pseudomonas will emerge lately but frequently in these cases. So we have to target these patients, and luckily we have new agents to target efficiently these cases. So we saw previously that we have some issues for treating these patients, and the conventional therapies, whatever considering piperacillin, tazobactam, and even carbapenems, could face the issues of resistance. So we have these days new drugs, but as you can see, if ever many of the gaps have been filled in these new drugs, there is some remaining issues. So of course, Acinetobacter is not a major problem in Europe, but when you go in the eastern countries, this is an endemic situation, whatever considering community or even nosocomial cases. And we remain having some issues with difficult to treat Pseudomonas. By the way, it's important to mention that this drug has been launched quite recently, and the data supporting their use in multi-drug resistant pathogens in intra-abdominal infections are, for the moment, quite limited. But we can assume that ceftazidime, which was an efficient drug, mero or imipenem, will be also efficient in this setting. And when you look at the global panorama for gram-negative and non-fermenting gram-negative bacilli, as you can see, there is some gaps filled, especially with cefiderocol. But as I mentioned previously, we don't know at all what will be the efficacy of cefiderocol in this setting. Hopefully, in many circumstances and in daily practice, we can still rely on more conventional therapies. And for gram-positive cocci, except for tigecycline and linezolid, there is no new and real efficient treatments, suggesting that today we will still rely on probably linezolid in many cases, even if, while the drug has been launched almost 20 years ago, there is extremely limited data on the use of linezolid in intra-abdominal infections. Then we have to go on the issue of rapid diagnostic tests. For the moment, we rely on microbiological cultures, but there is new data suggesting that multiplex PCR techniques could be useful, and there is one test called the Univero cartridge, launched recently and assessed in the registry trial, showing that for a large cohort of 300 patients with peritonitis, but infected ascites and many other abdominal issues, the authors demonstrated a good sensitivity, good specificity, and also a very good negative predictive value. This test will be able to bring the identification of the pathogen on one side and the most frequent resistant genes on the other side. So this is the reason why a prospective trial has been started recently called Direct Abdo with a cohort of patients with intra-abdominal infection in the postoperative context. And this patient will be randomized at the time of reoperation to be followed by conventional microbiology on one side. So this is, this one, conventional microbiology, or the rapid diagnostic test with the purpose of evaluating the delay for having the adequate therapy as soon as possible. De-escalation and all the process for reaching an adequate stewardship. So de-escalation has been largely proposed in many instances, especially when you get an appropriate therapy, a broad-spectrum antibiotic therapy, and positive microbiological cultures. Of course, it's more difficult in case of polymicrobial infections and presence of multi-drug-resistant pathogen, which is typically the case in many intra-abdominal infections. So here are examples of several studies in which de-escalation was performed. And as you can see, in these cases of intraabdominal infection, surprisingly, but in fact not surprisingly at all, because we are here with polymicroid infections, there is not that much de-escalation cases reported. But of course, when you are able to de-escalate, it's of better prognosis. We can talk also of biomarkers. While C-reactive protein, or PCT, have been demonstrated to be useful for the initial diagnosis, it's much more debated, and there is today no undebutable randomized trial assessing the value of PCT or CRP to be able to predict the treatment response and to tailor the duration of antibiotic therapy. And this is the reason why we have today two randomized trials. This one, the Stop It trial by Rob Sawyer and co-workers, published in 2015, and analyzing the group of limited severity cases. So this patient, community-acquired, healthcare-associated cases, but with, as you can see, a very low Apache 2 score, were randomized into two categories. A first group, control group, 4 days antibiotic or until the patient was better, not febrile, with decreased white blood cell counts and return of gastrointestinal function, or an experimental group of 4 days strictly of antibiotic therapy. They analyzed the population. In fact, the trial was stopped for futility at an interim analysis, showing no differences in terms of both groups. The graphic here illustrating the proportion of failure reported as reoperation or death. And overall, the authors obtained 20% therapeutic failures in each arm, but today the general assessment is that 4 days of antibiotic therapy for patients with moderate severity are totally acceptable. And then we have the DuraPup trial performed by French teams and published in 2018, assessing the duration of treatment, this time in ICU postoperative cases, so a short arm, 8 days of therapy versus 15 days of therapy. And again, in blue, the good news. The good news is that when you use 8 days, you will have more days free of antibiotic at day 28, with a similar length of ICU and hospital stay. The bad news is that we recorded at this time a significantly or almost significant proportion of drainages reported between day 8 and day 28, here 0.44, and almost significant proportion of bacteremia in the cases who underwent the short course of therapy. Last point is related to the analysis of these clinical failures. Overall, and among the 236 cases in the DuraPup trial, we reported 60% of failure. It could be surgical failure, needing reoperation or drainages, microbiological failures, or death. And when looking to the risk factors, there is one important flag and not explained. Documented piperacillin therapy was reported with an increased ratio in case of overall failures, so considering the whole population, and same story in case of surgical failures with an increased proportion of cases with documented pipta therapy without any clear explanation. So to summarize, source control is absolutely fundamental. Antibiotic therapy as soon as surgery, of course, targeting enterobacterials and anaerobes, based, of course, on local and regional data, so meaning that you have to go to look at your microbiologist and ask them what are the ecology. De-escalation is feasible, and a short duration of treatment or a shorter duration of treatment when compared to what we used to do is also a feasible approach. Thank you for your attention.
Thank you, Philippe, for this my presentation. We have time for one short question, if any. Very briefly, could you tell us what would be for you the main criteria to recognize early treatment failure? What time, what criteria?
Debated question. Let's say that tachycardia is probably the most earlier sign. Then you have dyspnea, then you have pain, but tachycardia is probably something very relevant. Not specific at all, I agree, but very, very sensitive.
So, since there is no comment or question, thank you, Philippe. We will move on.
Sorry, there is a delayed question. Sorry. This is,
Sure.
thank you for an entertaining and informative talk. This is not directly related to bacterial treatment, but when would you consider empirical antifungal cover in these patients, especially those who have tertiary peritonitis, as in a leak after primary peritonitis?
So for the sake of time in my presentation, I removed all was what based on the fungal therapy. So the criteria for multi-drug resistant pathogens are exactly the same for fungal positive therapy for positive patients. The point is that when compared to intraabdominal infection, bacterial infections, we never know if the fungal samples are related to colonization on one side or to an authentic infection on the other side. So let's say that when you have a patient in multi-organ dysfunction, especially in case of, as you mentioned, tertiary, but also postoperative peritonitis, we will treat this patient rapidly, usually using echinocandins because it will cover the large panel of all the candida involved. And then we will discuss. But remember that with fungal agents, there is no good biomarkers, and there was recent data suggesting that beta-glucan is not efficient enough to determine if there is a real infection. And in addition, we don't know what is the duration of therapy. Remember that neither the ESCMID nor the IDSC guidelines gave us any recommendation for duration of treatment of these cases. So it's a bit more difficult, and this is the reason why I skipped this paragraph.
Thank you.
Okay, now we move on to Dr. Siriwardena, who will discuss with us when to give or when not to give antibiotics in acute pancreatitis.
Okay, so good afternoon, chairs, ladies and gentlemen. It's my privilege to be with you here, my first time at Isicem. This is the title of my talk, When Not to Give Antibiotics in Acute Pancreatitis. So when I got this title, I thought this feels a little bit like that thing we had in the UK. Some of you may remember. It was called Brexit, where you could remember in the media there's all yes, we must have Brexit, or no, it's very bad. So this felt like one side of a two-sided problem. So I've slightly altered the title to Rational Antibiotic Stewardship in Acute Pancreatitis. I will focus on the note, but that's really kind of, I think, what we're looking for here, when to give antibiotics, but also when not to. This is my disclosure slide. And the reason why I altered that is that I think, as Dr. Coopersmith said at the start, if you have an infection, antibiotics can be life-saving in the treatment of that specific infection, and nobody in this room would argue with that. On the other hand, against antibiotics, they're ineffective either in the absence of infection or if incorrectly used. Overuse, as we've heard, promotes antimicrobial resistance both in the individual and in the community, and globally, antibiotic resistance is legitimately regarded as an existential threat for mankind in the 21st century. So it is something that all of us have a duty to be aware about. The International Association of Pancreatology and the American Pancreatic Association produced these guidelines, and I'm going to focus now on acute pancreatitis. We haven't heard a lot about that so far this afternoon. These are the evidence-based guidelines. They're 10, 11 years old. They're in the process of being redone. And they said, don't use antibiotics for prophylaxis. There is a whole series of randomized control trials. There's several meta-analyses and 2 Cochrane database reviews which show that there is no beneficial effect of antibiotic prophylaxis in patients with acute pancreatitis. That's very clear. What about treatment? So this statement, and I remember I was in the room in Chicago when this statement was discussed, was very controversial, because of the risk that you say, okay, patients with infected pancreatic necrosis, you can treat just with antibiotics. So intravenous antibiotic therapy should be used in case of suspected infection. but further intervention should be considered. That was the sort of qualifying sentence. And that actually now, if you rewrote these guidelines, that would be a bit more complex. The other paper to talk about is the 2012 update of the 1992 Atlanta Consensus Conference on Acute Pancreatitis. The 1992 document divided acute pancreatitis into acute mild and acute severe. And that really didn't work because there is a continuous spectrum of severity. Even this is probably too dogmatic, but it does work after a fashion. So mild acute pancreatitis has no organ failure, no local complications. Moderately severe disease has transient organ failure, which responds to resuscitation. And severe acute pancreatitis has persistent organ failure, the kind of entity that you will be familiar with treating. So what's the problem then with antibiotics and acute pancreatitis? And there is a problem. It's this: the National Confidential Inquiry for Perioperative Deaths initially looked at just perioperative mortality, but they're an NGO, a non-governmental organization, who are funded to undertake surveys of clinical practice. And in 2016, they looked at acute pancreatitis across the United Kingdom. And this is one of their key highlight sentences. They said a particularly worrying aspect of the report was that over 60% of patients in this study were prescribed antibiotics despite the guidelines saying that it's not effective in preventing complications. Is this just a problem for the UK? Are we like an outlier? Actually, the answer is no. This is a study that we did some 8-9 years ago, which looked at questionnaire surveys of the management of acute pancreatitis, and there are lots of those in the literature. So 8 studies, 2,397 physicians. The lowest use of antibiotics was 41%. The highest was 88%. So antibiotic overuse is common. This was the USA, Cape Town, India, Australia. So it's a global phenomenon. Why is antibiotic overuse so prevalent in acute pancreatitis, and what constructive solutions can you maybe come up with to avoid that? So the reason why is that there is an almost complete phenotypic overlap between inflammation in acute pancreatitis and infection. And it used to be taught that inflammation was a chemical phenomenon, cytokine overdrive, and that infection was later. I think the reality is more complex than that, and I haven't really got time to go into that. We've heard all about the gut changes in this, but the end result is that the phenotype between infection and inflammation overlap completely. So one particular strategy is maybe using procalcitonin, and this is an old systematic review from the Edinburgh group, which showed that procalcitonin, I don't think these are going to project very well, had quite a high sensitivity and specificity for detection of infected pancreatic necrosis with a high area under the curve of 0.9. From this, we went on to do this study, and I'm going to focus on this study a little bit because it's potentially relevant in this area. So this is PROCAP, which was a single-center, patient-blinded, randomized controlled trial of the use of a procalcitonin algorithm in patients with acute pancreatitis. I think you all know about procalcitonin, so I'm going to pass over this slide. The aim was to test the hypothesis that a procalcitonin-based algorithm to guide initiation, continuation, and discontinuation of antibiotics will lead to reduced antibiotic use in patients with acute pancreatitis without an adverse effect on outcome. So, as I said, it's a single-center, randomized controlled trial. It was going to be a multi-center trial, but COVID intervened. So it's a single-center, randomized controlled trial with the intervention being a PCT measurement-based algorithm. Inclusion criteria were pretty standard. Patients over the age of 18 able to give informed consent with 2 of 3 Atlanta 2012 criteria, either clinical, biochemical, or radiological. Exclusion were inability to provide informed consent, and those patients who had conditions which mandated prolonged antibiotic therapies, for example, if you were immunosuppressed for some reason or other. When one designs a randomized controlled trial, if it's a good study, then the care in both arms should be the same, with the sole difference being the intervention under study. So here, the standard care in both arms, intervention on the left and control on the right, was the same. Mandated antibiotic use clearly had to be allowed in both arms. So for culture-positive results and for intervention prophylaxis for laparoscopic cholecystectomy or endoscopic drainage of sepsis, you had to allow that. So the sole difference is empiric antibiotic use. In that situation where clinicians thought, okay, I want to use antibiotics, but I haven't got any evidence to use it. We also had a safety override, so that if a clinician said, I really want to use antibiotics, they could do. This is the algorithm. I don't know how well that's going to project for you as an audience. This is a simplified version. We discussed this at length with Philippe Montravers, who is the kind of guru of procalcitonin trials, about using a graded yes-no, less than 0.25, don't, 0.25 to 0.5, think about. And I felt that for a surgical audience, that wasn't going to work. So for surgeons, you just needed a yes-no. That's kind of, that's how we work, I realize that's a slight simplification. Yes, do it, or no, don't. So if your PCT was less than 1, don't prescribe antibiotics or stop them. We said check it again in 24 hours if you wanted to, if you're still concerned about it. If it's still low, don't. If it's above 1, then yes. And of course, you had the safety override. If you felt it's less than 1, I really want to give antibiotics, I'm not going to be happy unless I give antibiotics, you could do. And we recorded algorithm override. So participants were randomly assigned 1-to-1 to either PCT-based care or standard care. And to avoid imbalance in the trial, we had 2 stratification variables. One for disease severity, mild versus moderate and severe, and the other one was admission pathway. So in the UK, the Manchester Royal Infirmary is a tertiary centre for a population of about 3.2 million. So we get about 20% of our patients with pancreatitis are transferred in after a variable time elsewhere. So we wanted to avoid cluster of those in one or other arm. So stratification variable was by admission pathway. The statistical analysis, so this was a superiority design because I felt there was no point doing an equivalent study. So the null hypothesis is that it doesn't make a difference. We knew that about 60% of patients with acute pancreatitis receive antibiotics, so a 20% absolute change, needed 130 patients in each arm, 260 in total. I'm just going to ask you to focus on the primary outcome measure, which is quite a tough one, which is the primary outcome measure was antibiotic use, the binary endpoint, yes or no. You received antibiotics, yes, or antibiotics, no, during any time in the index stay. Approved by ethics committee and protocol published prior to recruitment, open to recruitment in 2018, closed in 2020. Moving on to the results. So it's not going to project, but 130 patients in the intervention arm, 128 in the control arm. In terms of patient characteristics, there was no difference in terms of age, gender, or severity of disease. Just draw your attention to the fact that about 20% of our population were bona fide severe acute pancreatitis. The admission route was no difference between tertiary and direct admission. No difference between organ dysfunction score, no difference between etiologies between intervention and control. The next slide is all of the results, everything on one slide. So you can see that the intervention was associated with a statistically significant reduction in antibiotic use. Once the prophylactic use was excluded, that significance persisted, and this translated into a reduction in terms of days of antibiotic use. There was no difference in all-cause mortality, and if we'd done this study 20 years ago, I don't think you would have seen that 3%, 2% in severe acute pancreatitis. For some reason, the mortality is generally quite low, but there was no difference between intervention and control. No difference between clinical infections, hospital-acquired infections, length of hospital stay, or cost of stay. There is a separate, more complex cost analysis, which I don't think I'm going to have time to show you. On the forest plot on the left-hand side, it's if it favors intervention. So these are subgroup analysis, which we weren't powered to do, but I'm sharing them with you. So there's no difference here. The benefit is still there for both mild and severe, for direct and tertiary. The benefit was lost during the post-COVID group. That's probably because the recruitment was almost done by the time COVID finished. So in conclusion from this study, our findings suggest that procalcitonin-guided care can reduce antibiotic use without increasing infection or harm in patients with acute pancreatitis. PCT algorithms to guide antibiotic use should be considered in this care of this group of patients and be incorporated into future guidelines on the management of acute pancreatitis. Coming back to my question, my last couple of slides, so patients with mild and moderate acute pancreatitis do not need and do not benefit from antibiotics. unless they're used to treat a specific proven infection, you get a lab result which says you've got a UTI or a chest infection, or as prophylaxis for a specific intervention, lap chole or endoscopic drainage or something like that. Similarly, patients with severe acute pancreatitis do not benefit from antibiotic prophylaxis or blind antibiotic therapy. It doesn't make a difference, and as Dr. Montravers says, it just increases resistance in the community. Focusing on patients with severe acute pancreatitis, if they're transferred into you on empiric antibiotic therapy, and the median number of antibiotics in patients transferred into our hospital from elsewhere was 4 antimicrobials, so 3 and an antifungal typically. What we tended to do was stop all of that unless there was evidence of microbiology, and remarkably, there quite often wasn't evidence of positive microbiology. Stop the antibiotics, reculture, maybe change the lines, measure procalcitonin. If it's low, there's no need to start antibiotics. Clearly use antibiotics for culture-proven infection. If there's CT evidence of necrosis, which will be almost prevalent in that population, that in itself is not an indication for antibiotic use. The more complicated area, to be honest, is CT with a collection, necrosis with a collection, where you may need to be thinking about something because we're trying to shepherd that patient to 21 days to delay the intervention. So, and also, to be fair, you might need antimicrobial therapy in a sick patient with necrosis, typically with a collection, without positive microbiology, when you're worried that you might be missing something. And I think it would be unfair and unrealistic to say no antibiotics in that situation. Thank you very much for your attention.
Thank you for some clear statements. We do have time for 1 or 2 short questions. There is one over there.
Every single patient I see in the ICU with pancreatitis has necrosis and a fluid collection, 100% of them. What do you do with those?
So I thought you might say that. So that's an ITU population with necrosis and a fluid collection. We have currently 3 of those in our ITU. We'd still run so now what's happened is that the PCT algorithm has become kind of standard of care in large parts of the UK. We'd measure PCT. If it's low and there's no proven microbiology from anywhere, so chest, urine, blood cultures, all of those are clear, we would not routinely have that patient on antibiotics. Do we use FNA, fine needle aspiration necrosis? We used to use that maybe 5-10 years ago. It was the Hans Beger German group who really promoted that. And I was speaking to Nick Zromsky from Indianapolis recently. It's kind of disappeared to death. We no longer use FNA. I don't quite know why we don't use it, but we don't use it. So very much close clinical observation, but just having necrosis, just having a collection, doesn't mean that you're going to be mandated antibiotic therapy, which is the closest I can give you to an honest answer on that one.
Okay, so looks like there's no further questions. So thank you very much.
Thank you.
So now the next speaker is Dr. Ashish Khanna, going to talk about intra-abdominal pressure issues. Yeah.
Hello. So I'm going to take you all to a certain different aspect of abdominal issues, which is understanding intra-abdominal pressures and how they affect organ perfusion. Again, for those who've been to my talks, standard slide. Welcome from, this is me looking out to the Blue Ridge Parkway in North Carolina. And this is where I work at the Wake Forest School of Medicine, and affiliations and relevant disclosures. So a very basic start to this is the definitions of intra-abdominal pressure and intra-abdominal hypertension. And I'm sure all of you in the audience are well aware of these numbers. The Abdominal Compartment Society, they've actually redone these guidelines, and there is work being done as we speak to redo them again. But the numbers haven't changed. So normal, 5 to 7, and then we can identify the grades, grade 1, 12 to 15, grade 2, 16 to 20, grade 3, 21 to 25, and grade 4, more than 25. And then we also talk about more than 20 with evidence of organ system failure needing surgical intervention. So keep those numbers in mind. But then I'm going to switch gears to another number that's very relevant for us in the critically ill population, which is mean arterial pressure or hypotension or blood pressure. And we've looked at these numbers in several different ways, but we do know that a MAP 65 is important. We did this analysis with a large retrospective data set, and we saw that with every time-weighted average of time spent below a MAP 65, there was a pretty strong association with acute kidney injury, myocardial injury, and mortality. The other interesting side of this work that we did on 10,000 patients out of a large retrospective data set in the US was when we looked at various different thresholds of mean arterial pressure. We started with a map of 85 as our point where we first saw an increasing odds of mortality, AKI, and myocardial injury. Now again, happy to take up that discussion. A lot of people say, well, map of 85 is, we don't associate with it. That's not supposed to be the map we're supposed to aim for. But Marlies Osserman and Pierre Asfar, and you all know Pierre Asfar, he published the only large randomized trial, well-powered randomized trial of septic shock and blood pressure targets, wrote this editorial and very aptly titled it Map of 65, Target of the Past. And they referred to our work. And the bottom line here was, let's stop focusing on these magic numbers of MAP of 65 or 75 or 55, but let's try and focus our attention to perfusion pressure because we're forgetting the other side of the equation. So mean perfusion pressure or abdominal perfusion pressure or renal perfusion pressure is the difference of MAP and CVP or intraabdominal pressure, whichever is higher, right? But one of the problems is what's better, CVP or intraabdominal pressure? Well, the jury is out there. This is just some experiments done in the lab that show that if you give fluid, CVP becomes high and stays high, whereas intraabdominal pressure tends to shoot up, so it's sort of more sensitive when you do give fluids. Now, yes, the overall compliance of the abdominal cavity does determine how the intraabdominal pressure behaves. But just to look at it in a more simplistic manner, and I refer to this nice review that Bernd Sagel authored, we need to focus on perfusion pressure, which is a balance between what's driving flow, which is cardiac output, mean arterial pressure and vascular resistance on one side, and outflow pressure on the other side. So, do we measure perfusion pressure? We don't measure intraabdominal pressure continuously. We usually only do it when we're worried about it in patients with acute pancreatitis or acute abdomens where we feel the abdomen's tight. We did a neat experiment. In our post-cardiac surgery population, we routinely measured intraabdominal pressure, but continuously. And we did it in a observational manner. We did not intervene. We did not even look at the intraabdominal pressure values while they were being measured. And in this data, part of this data that's published, we did see that high intraabdominal pressure was common and persistent in a post-cardiac surgery population. So if you follow the arrows there, about 20% of our population had a intraabdominal pressure of more than 15, actually more than 20 there, for at least 10 consecutive hours in the post-cardiac surgery unit in an average duration of measurement of 2 days, right? So persistence of high intraabdominal pressure, if I translate it back to the equations I have on the screen there, that does mean that if we keep a map of 65 and we have persistently high intraabdominal pressures like that, we're probably not achieving adequate renal perfusion pressure. So are we doing justice to our patients? Well, the other thing, this is from the same study, we saw these patterns here, right? So in the blue is intraabdominal pressure. The red vertical line is end of surgery. And then if you follow the blue intraabdominal pressure trace, it creeps up towards the end of surgery, and then it stays up as the patient enters the ICU and keeps creeping up. Whereas the urine output, which is pretty high intraoperatively, this is cardiac surgery, then starts dropping off as the patient gets into the ICU as intra-abdominal pressure goes up and stays pretty low. It actually drops down below 0.5 mils per kilo per hour. So interesting behavioral patterns of intra-abdominal pressure we've uncovered with this work, and there's more to follow. But if you look at, for example, here is a nice editorial that I published with Manu Malbrain. The issue with intra-abdominal hypertension and intra-abdominal pressure is that it's actually a moving target. We tend to fixate on, oh, the intra-abdominal pressure is 15, I should be worried about it, or it's 20, I should be worried about it. Well, that's okay if your patient has a normal ejection fraction and a normal heart. But if your patient does have some element of diastolic dysfunction, right, and has heart failure, which is pretty prevalent, then that trajectory, that upslope, is pretty dramatic. Then you'll start seeing features of organ system failure at a lower level, and your pressures, intra-abdominal pressure, is not going to sort of stay flat and go up, but rather it's going to go up pretty rapidly. So we need to watch out and need to be very cognizant of the focus on the numbers versus focusing on the patient. Lots and lots of studies here on this slide, just trying to show you the data from this nice systematic review that Manu Malbrain published. And the important part is, yes, we've been measuring intra-abdominal pressure now for decades, but most studies are single center, observational, and intra-abdominal pressure, again, measured very, very intermittently, although the data does suggest that there's a pretty strong association with mortality and organ system failure. So does it influence mortality? Short answer, yes. In this systematic review, about 30% patients who entered the ICU had intra-abdominal hypertension on admission, and that in and of itself, intra-abdominal pressure, they took the point of transition as 12 versus less than 12 or more than 12, and that was a predictor of mortality. Again, this is, I think this all of us know, but let's just look at, I love bringing up this study because it's actually, in my opinion, one of the largest and most well-done studies. Now, 2005 when this was done, this was 14 ICUs, 265 patients with very different patient types, intra-abdominal pressure measured twice daily. Here you can see the distribution of high intra-abdominal pressures. I'd say to be expected curve here, with most intra-abdominal pressures between 8 and 12. And then the percentage of patients dead or alive, the dead ones being in the dark bars. As the pressure reached higher, there was more patients dead than alive. Interestingly, if you separated out patient trajectories over the first week, the dark bars here are the box plots, the whiskers, and the dark bars here are patients who did not make it out alive. There was a clear separation of intra-abdominal pressure trajectories in the survival versus non-survival group. And again, that reflects in this cumulative survival curve. The development of intra-abdominal hypertension during ICU stay was an independent risk factor for mortality. So the message, again, is loud and clear. Now, when we measure continuous intra-abdominal pressure versus measuring it intermittently, things get rather interesting. Now, all of this data, and lots of studies on this, are intermittent measurement of intra-abdominal pressure as we do it, normally done once or twice a day. And again, if we look at the prevalence of intra-abdominal hypertension, it's about 30 to, in some cases, 45, 50% here. And yes, like I've said, association with mortality. But what happens when we start measuring intra-abdominal pressure continuously as a routine, vital sign? This is our published data where we saw up to 80% or 90% patients had IAH grade 1. And again, the prevalence rates here, even IAH grade 3 was up to 47 and in the 30s and 40s in terms of percentage points. So again, are we missing a key vital sign by not continuously measuring intra-abdominal pressure? And is its relevance more than just the acute abdomen? Rather, its relevance is measurement of perfusion pressure. We also looked at a distribution of BMI and intra-abdominal pressure, and as is pretty obvious there was no significant difference, but there was an uptrend as body weight increased, intra-abdominal pressure did go up. We were also asked to examine what happens to the extubated patient, where what happens to the sedated and intubated patient. So the purists will say your patient was not paralyzed and abdominal musculature was not relaxed. Well, we went all the way back and we started looking at -6 hours. This red line is the point when the patient was extubated, and there was an uptrend in intra-abdominal pressure even in the sedated and intubated patient. And yes, it became pretty high when the patient reached point of extubation and then stayed high. Now, the controversial side of this is, why are we only focusing on intra-abdominal pressure in the sedated and intubated patient? Do we need to change our approach? Because if we want to measure abdominal perfusion pressure, I think renal perfusion pressure is important, whether you're totally sedated or paralyzed or whether you're not, because we still want to achieve adequate perfusion to the kidneys. So it's not just the sicker patients who are intubated and deeply sedated. Other patients in the ICU also need the renal perfusion pressure measured. So that's the other interesting side of what we should or should not do. Again, busy slide here, but this nice review we wrote with Manu Malbrain on the pathophysiological and clinical implications of high intra-abdominal pressure. I'm sorry, this is probably not worth your time today, but I have the reference at the bottom if you guys want to look at it. In the same review, we also talk about what we can do with the raw intra-abdominal pressure tracings. So if you follow it right here, you can look at the delta intra-abdominal pressure, which is the compliance of the abdominal cavity. You can actually go and find the heart rate, and then if you compress this trace, you can actually do pulse pressure variation as a surrogate from the raw intra-abdominal pressure tracing. So there is a wealth of information that is going to come if we actually measure and then keep all these waveforms and generate all of this data for ourselves. Clinical implications, I'll just bring up one example from some published data. This is renal transplant patients where intra-abdominal pressure was measured, and for example here, it does show significant correlation with renal resistive indices and urine output. Again, poor performance post-transplantation. It is pretty evident that high intra-abdominal pressure would govern that. So as I conclude, I'm going to talk about the future in 2 or 3 slides. So what is the future? I do feel that we need to consider intra-abdominal pressure as a key vital sign, and at least in the critically ill patient, have the ability to measure it seamlessly, because it would translate into things like this: predictive modeling for AKI, where we use continuous urinary output, intra-abdominal pressure, baseline creatinine, and race. This is a particular model that was published by some colleagues, and this is a model that is still under development. But that's the future, right? So patient trajectories can be predicted if we use intra-abdominal pressure continuously. The other part, going back to the editorial that Marlies authored with Pierre Asfar, I think the time has come to look at perfusion pressure as a marker for resuscitation rather than just focus on absolute numbers. I know that there is not just one way to measure perfusion pressure. There's several ways to do it, but let's just move away from just focusing on that map of 65. Thank you all for your attention.
Thank you. There's time for one question or comment from the audience. Where?
In the middle.
Yes.
From Chile, right?
Yes. Hello.
Hello?
The microphone is coming.
Thank you for your presentation. May I ask, what is your personal approach when someone has abdominal hypertension? Because if you say, okay, I want to put the BP higher, like giving fluids or giving vasoactive drugs, you are also worsening the problem of ischemia in the gut. So what is your personal approach?
I knew this question would come. So my personal approach would be not just to drive the blood pressure up, but to also consider de-resuscitation. I think we are a culprit in that we often leave our patients hanging on excessive amounts of maintenance fluids in the ICU, and then we allow that fluid creep to happen. So my approach would very simplistically be increasing pressure, but also de-resuscitating at the same time. Now, your point with gut perfusion is well taken. And again, I don't have the data today to prove or disprove you, but I'd say a more balanced approach to vasopressors would probably save the day with that case. Now, I will tell you that our plan is to do a randomized trial where we do intervention based on abdominal perfusion pressure targets rather than mean arterial pressure targets. And I'll probably be in a better situation to answer your questions once I have those results. Thank you.
Okay, thank you very much. We need to move on to the last presentation, and that's going to be Dr. Kaplan, Open Abdomen, ICU Management Priorities.
Thank you. Let's see. Slides. There we go. These are my disclosures, none of which are financial. I am a surgeon, therefore I will have pictures, maybe not so many words. These are the things that we're going to cover, and it will ultimately bring us to what opportunities there are for all of us as intensivists when the patient does have an open abdomen. You can't hide from this stuff. It is everywhere, whether you use a continuous monitoring technique or every couple of hours. And we don't use continuous. We'll see about all of Ashish's data later. Indications for the open abdomen are several. Whether it's trauma or emergency general surgery, you are familiar with these. What it does do is it puts you in a position of having to help manage that open abdomen in conjunction with the surgeon. Sometimes a difficult task. This is one of my early patients. You can see we don't use this anymore for the most part. This is a bowel bag with a piece of polypropylene mesh. You can see the intestines, but it's not very good at managing fluid, and of course there is no negative pressure. You can see this technique in some low and middle income countries where we don't have negative pressure therapy. Now you can make your own, and this is a schematic, and you can see here that this is a bowel bag that covers the bowel, and it gets down to some of the intraabdominal contents, but it still allows a lot of the viscera to come in contact with the interior aspect of the intra and lateral abdominal wall. You have to be a surgeon to say that quickly. All of this is arranged over top of some towels and some Jackson Pratt drains, and you're familiar with this. It looks like this. This is a homemade vacuum-assisted closure device. You can use this with ostomies or feeding tubes. It is, as you can see here, designed for the stuff that does not fit. You can have a proprietary vac. You're familiar with this from the Kinetic Concepts Incorporated system, and this has a little rosette and it attaches to a suction device. It's all very lovely, creates negative pressure, and takes care of all the fluid. But it also does not significantly retard adhesion formation. So there's a new version, and it looks like this. It has these arms that extend all the way down. This is the Abthera device, and when you put it over top of people whose intestines don't fit, it looks like this. This is delightful because it makes sure there aren't adhesions. Now, part of your role is to make sure that when we protect the patient from developing adhesions, everything will then fit back inside. But there are challenges in doing all that. Some of those challenges are identified in the International Registry of the Open Abdomen. You did know there was an International Registry of the Open Abdomen. Of course you did. So when you look at 640 patients, only 17% came from injury. The rest are emergency general surgery patients. Negative pressure wound therapy, not so prevalent, 47%. Open abdomen days 8, mortality is high. And the reasons for that. If you don't fix the volume, and Ashish alluded to this, this is now a couple of weeks in. Look at the size of the viscera, and there's inflammation, there's edema, it is woody, it does not become very pliant, and it certainly doesn't fit. When it really doesn't fit, you can't close it, and therefore you may end up with an isomental apron over top of everything. This is great because it protects the viscera, but you can't close that either when the lateral abdominal wall has retracted and is salt and water laden. Therefore, you might, and this is one of my partner's patients, I didn't do this one, you might put a skin graft over top. When the patient coughs, if that tears away, it also ends up creating holes in the viscera, and you end up with the dreaded enteroatmospheric fistula. This is a disaster for the patient. Your role in the ICU helps get rid of this. But there are problems along the way. If you look at all of the open abdomens, enteroatmospheric fistula, like you just saw, and up to a quarter. Intracutaneous fistula, more represented after trauma, less after emergency general surgery. Ventral hernia is common. This is a lot of my elective practice. And the difference is that the enteroatmospheric fistula require repeat operation, while about a third of the intracutaneous fistulae will close spontaneously. So watchful waiting is helpful in that set. Obesity makes this worse. Besides increasing your intra-abdominal pressure, it also complicates your stay. If you look at patients that have, I have no more pointer, peritonitis or injury, and you base your analysis on whether they are or are not obese, obesity makes everything worse. They have longer length of stay, and they have higher pressures, and they are more likely to have open abdomen days. Let's talk about how you manage salt, water, and organ volume, because the notion of visceral edema is one that impacts care. Deresuscitation is excellent. This is the ROSE approach: resuscitation, optimization, stabilization, and evacuation. Look at the time frame. Stabilization in days, evacuation 2 weeks. This patient population doesn't fit. You need to evacuate the resuscitation salt and water earlier than weeks, because you must get them closed. This is what you need to avoid. This is at day 5. Your opportunity for action is earlier than that. We're going to talk about what that is. This is a protocol. These two references, the first one was the articulation of the protocol, the second was the results. For all the patients in this center that had an open abdomen, they did the following things. No maintenance fluid. Resuscitation fluid as needed, but driven by some kind of objective measure. Every single patient had hypertonic saline that ran at 30 mLs per hour, is 3%. VAC losses were replaced only 1/2 to 1 ml. Everyone went back at 24 to 48 hours, most of them at 24, to be honest with you. And they all placed a nasojejunal tube for enteral nutrition at the first operation, the first take back. And they had a tiered fascial closure approach, which meant that if they couldn't close everything at the first or second relaparotomy, they closed some of the top and some of the bottom, leaving a smaller and smaller and smaller space. What happened was exactly what you wanted. If you're looking at the percent with an open abdomen, and the x-axis is in hours, it's about 3 to 4 days, substantial reduction in the people left with an open abdomen. This is exactly what you can do. There's often resistance with pharmacy to giving you the 3% hypertonic saline solution, but you need to advocate. Everyone is concerned about the induction of acute kidney injury when you're using 3% hypertonic saline. Remember that the abdomen is still open, and therefore you have a dialysis-like effect and clearance across that peritoneal space. When you look in this patient population, the dark bars, the solid bars, are those who received hypertonic saline. The hashed bars are those without. There is no statistically significant difference in AKI by any stage at admission, the first temporary abdominal wall closure, and up to 7 days. So this is a safe thing for you to do. You do have to manage the chloride, because this chloremia has an impact on mortality, and it's U-shaped, and you can see it displayed here. If you are hypochloremic or hyperchloremic, and there are various models that identify odds ratios for enhancement of mortality, if you're low or if you're high, you need to avoid this. And with a 30 ml per hour solution, you don't have this problem. So it is ultimately safe in this patient population. There's another option. Anybody seen direct peritoneal resuscitation? Great, one person. It was lots of fun. Now, what this does is it leverages the peritoneal surface. For absorption, it uses dialysis fluid, which we use for fluid management in patients with chronic kidney disease. The 2.5% glucose PD solution, first hour is 800 mLs an hour. The next several hours until you're done are 400 mLs per hour. It looks like this. Through an incision, you put in a couple of drains, you have a perforated drape, and then you cover it and you place an egress catheter. So that what you end up with is 2 inflow and 1 much larger outflow. Therefore, you superfuse the peritoneal space as if you have continuous peritoneal dialysis. And it does exactly that. It takes off salt and water, and it makes sure that your patient, if they were hypothermic, now have the maintenance of normothermia. These are all the benefits. Vasodilatation, salt and water management, much higher primary fascial closure rate, decreases your cytokine burden, that's been sampled, huge cytokine loss through the peritoneal space, and for those that are not having other dextrose intake, this supports cerebral glucose metabolism, important for those who have some degree of hepatic insufficiency. You cannot use this if you have ongoing hemorrhage or you've packed the abdomen, so it follows in the wake of those things. This is the Western Trauma Association Critical Decisions in Trauma Committee recommendation for the management of the open abdomen. You should read all of this. You can read all of this, can't you? Nowhere is hypertonic saline or direct peritoneal resuscitation. It has not caught on to these major guidelines, and this is one of those circumstances where practice is now ahead of the recommendation, which is very unusual. The primary fascial closure goal is absolutely essential because if you don't close them rapidly, diminished quality of life persists for 7 years, seems to be worse in men than women. They are more resilient than us. The uncompensated caregiver for those that develop PICS family, they are absolutely distressed by this, especially if your patient goes home and cannot take care of themselves because of the contents that are not in the right space. Axial strain and back pain is common, as is repeat admission, and not just elective admission, but unplanned admission. Now, you'll find things from 10 to 14% in the literature, but if you look in the trauma patient population, it is much higher. These are common reasons: infection, AKI, salt loss, wound management, and of course, reoperation or endoscopic closure of enterocutaneous fistulae. This all has a cost to it. In the meantime, how do you help this? You provide nutrition. Intact GI tract, it doesn't matter where you start feeding them. Most of the time I feed into the stomach. They are hypercatabolic, so we start at 2 grams per kilo per day for protein. We follow this with a 24-hour UUN after we reach goal. Recognize that for every liter of drainage you have across the vac, that's another 2 grams of nitrogen that you're losing. So you have to compensate for that. We generally use an elemental formula regardless of their NPO status. Since they generally have been hypoperfused, they may have been on high-dose pressors, and therefore the integrity and the capability of the glycocalyx to process complex nutrients may in fact be derailed. If you have this, you can't feed this gut not one bit. This person gets TPN. For those that have a lesser degree of compromise, they can have an elemental transition when they are no longer in discontinuity, but most of these patients end up on TPN for quite some time. If you have a proximal fistula, IR can help you guide a tube past that, and then you can feed them. If it is a distal fistula, if it's colonic, most of the time we can feed through that with tube feeds. There is not a problem. If it is more proximal than the colon, and it is of low volume, less than half a liter, generally that is also well tolerated. The fistula patients are the ones that come in with salt and volume loss. What can we do? A couple of things. Recognize that the open abdomen has multi-system effects. You can pick your organ system that you happen to love. Clearly, Ashish loves the kidney. This is all good for him. But there are others here, and every last one of them is impacted by the open abdomen. What I'll talk about here is posterior basal atelectasis. This is very typical, and you can see this for the patients that are now flat on their back, or maybe they are in the semi-recumbent position with 30 degrees head up. That lung gets atelectatic and compressed. The assumption is that if it's really atelectatic, you will have hypoxic pulmonary vasoconstriction, and therefore should not create issues with oxygenation. This is not always true. You can see on the right side here that there is densely atelectatic lung. When you look with color Doppler flow analysis, you still have flow in that region. You need to abrogate this so you can manage CO2 clearance and oxygenation. How do you do that? Recognize that with the open abdomen, this is the best chance for complete diaphragm descent. Things are not in the way. You don't have that tight fascial boundary. Therefore, you can deliberately recruit the posterior basilar segments. And that way, you reduce hypoxic pulmonary vasoconstriction, improve their cardiac output without additional pressors, And when they are ultimately closed, because you got rid of all that salt and water, they are now starting with an open lung, and it decreases their work of breathing. That piece is absolutely key. So I will leave you with these conclusions. This takes a team, and you must work with the surgeons. If you have to use crayon and block letters, this is okay. Most of us are used to that. 3% hot peritoneal saline is great for most, and direct peritoneal resuscitation, if they don't have bleeding and don't have packing, is a fabulous alternative. Early nutrition is fine. I start running tube feeds when I get back to the ICU, provided they are not on high-dose pressors, the same day. Anybody else do that?
So thank you very much.
I was on time.
We are just in time to make the stage for the next presentations. Thank you very much.
Perfect.
And I thank all of you for listening to this and all the speakers for their great presentations. Thank you very much.